Bismillah Rahman Rahim. Dr. Bilal, urology resident here. I'm going to start my presentation, and topic of today's presentation of mine is principles of urological endoscopy. The learning objectives are introduction, history, and basic equipments. We will describe in detail regarding the cystoscopy and endoscopy and conclusion. As far as the history of endoscopy is concerned, the Philip Posny, he invented the first instrument comprising a candle and a set of the mirror to look inside the human body. That is 1806. And Maximilian Kolnitze, he credited with the invention of the modern cystoscope in 1878. Now, in 2005, the Acme DC in 2010, a flexible cystoscope was the first digital endoscope. Now, as far as the endoscope is concerned, this is the tower of the endoscopy, and this is consisted of the various parts. It is consisted of the monitor. It is consisted of the light source, and this contains a camera, and this contains a video recorder and the printer. The light source, it is again of such as if the white light is used, the high intensity xenon and halogen, they are the source for the white light. But for the green light as well as for the blue light, the narrowband imaging, and it's used for irrigation purposes. For the use of the bipolar, the Nomus line is used. In the case of monopolar, the glycine and sorbitol and mannitol is used. Now, again, this tower, it can be mobile or it can be fixed. Now, these are the pictures and of the cystoscope, the rigid as well as the flexible cystoscope. We will describe in our subsequent slides. We will try to describe, although it is a vast topic, but in the nutshell, how much we can define. I'll try my level best to describe the most of the things. And the rigid cystoscope. Now, this actually, the rigid cystoscope, it works on the mechanism of the Hopkins rod system, which is consisted of the glass rods and then separated by the air. Now, now this rigid cystoscope, it has become an obsolete. We are using the semi-rigid, and these rigid cystoscopes, they had the advantages like that they got the large working channel. They can be easy to manipulate and they can be used. Now, the rigid cystoscope are made up of stainless steel alloy, and as far as the size is concerned, it is expressed in the French. 1 French is equal to 1/3 of the millimeter, or 1 mm is equal to 3 French. A length is different thing, and this is the size, and the circumference of cystoscope, that is the different thing. Now, the parts of the rigid cystoscope, the cystoscopic sheath, and cystoscopic obturator, the bridge, right? And this is the telescope. And we will describe the parts of each and every instrument of the cystoscope. Now, this is an assembly of the cystoscope. This is the ocular funnel, and this is the ocular window, and this is the light pillar through the light source of the taste. And this is a number of the cystoscopy sheet that is mentioned. And these are the ureter catheters that can be passed through this sheath through the working channel. And these are the inlet and outlet. This is the knob, right? And these are the markings and on the sheath. The distal markings are 10 centimeter, the wide of the markings, and these proximal 13 centimeter have got the markings. Now, this is an adult cystoscopic sheath that has got a length of 22 centimeter. Although the cross section, it is to be considered into the rounded, but that is oval, right? And this is an distal end of an cystoscope that is bulbous dorsally, and that allows easy introduction, automatic introduction of the cystoscope. While the Sentinel FR sheet that has got the different beak configuration, it hasn't got any groove or aggregation of the fluid, unlike then increasing in size at a 19 FR or 22 FR. This is again as I described regarding the size of the sheath and the numbers of the ureteric catheter that can be introduced. Now, regarding the bridge has got again bridge is when we are using the cystoscope, it can be integrated, it can be the detachable. The advantages of the detachable bridge are: number one, it helps in emptying the bladder efficaciously. It helps in clearing of the clots. It helps in passing the large size catheter, and it can be there can be the dual working channels. There can be even single working channel. And this is again a knob. This is the telescope, right? And these are the working channels of the bridge. And these are the obturator. Actually, this is an obturator of the cystoscopic sheath. This is the obturator of the resectoscopic sheath, and used for TURBT, right? And this is a Secchi's knife sheath obturator for the DVIU purposes. And this is obturator has got the differences between an obturator is that the knob of the resectoscopic sheath and the Secchi's knife obturator that is rounded, but conforming to the beak of sheath, it is present in the cystoscope, and the groove for irrigation at the distal end that is present in the it is not present in the 17 FR sheet. It is present in 19 FR and 22 FR, right? And while in the Secchi's and resectoscopic obturator, it is absent. The obturator of the cystoscopic sheath, when we are merging this obturator with the cystoscopic sheath, it does not extend outside this sheath, while this resectoscopic obturator and the Secchi's knife obturator, you have seen whenever we are assembling the resectoscope and the Secchi's knife, it extends outside of the sheath, right? And this is a locking mechanism having got the zero, and this is zero whenever we are introducing this obturator, it should coincide with the zero while merging with a sheath. And this is the telescope. Now the telescope has got the different color bands, and the color is denoting the angle and of the different types of the telescopes. We have written this whenever we are using the 0 degree, this is the green 0 degree lens, and this is the red, this is 30 degree lens, the black is 12, the yellow is 70, the white is 120. The 0 to 12 degree are used for urethral visualization straight above. For the bladder and for therapeutic purposes, we are using the 30 degree lens. And for inspecting the anterior infolator lens, anterior to the bladder neck, we are using 70 to 120 degree. Now, as far as the flexible cystoscope is concerned, this flexible cystoscope, actually, it has got several advantages. Number one, it can be used in office space. Number second is does not require a cystolithotomy position. Number third, it helps, and whenever we are maneuvering this flexible cystoscope, this the flexible tips helps in easy negotiation from the urethra into the bladder, and actually, it is that's why it is more superior than this rigid or semi-rigid. It has got the types of the flexible cystoscope again, and fiber optic and digital. Now the fiber optic actually that has got the coherent fibers and non-coherent fibers. From the non-coherent fibers, it forms the actually it carries out the light, and when the image is formed, that is through via the coherent fibers. Now, as far as the digital flexible cystoscope is concerned, that has got the chip at the tip. That means that this new generation has replaced the fiber optic bundles with the camera sensor. It has got the camera sensor in the distal tip, and it does not require a charge coupled device for the image formation. Does not require a camera, does not require a light source separately for the image formation. As far as on patient preparation, again, we all are very well aware regarding the preparation regarding the cystoscopy, the urine analysis and urine culture. It should be completed and all the infections should be treated. And before the scopy, the skin that should be prepared with a betadine rather than with chlorhexidine and alcohol, which can damage these mucous membranes of the genitalia. And lubricant gel instilled and aseptic techniques. Now, whenever we are inserting the cystoscope, we mustn't look for the meatal stenosis, and we should use the dilators for so that the sheath can be easily inserted. And the dilatation, at least it should be 2 FR. For example, if we are inserting the 22 FR sheath, it should be at least 2 FR wider than intended endoscopic sheath. In the woman, actually, this rigid cystoscope is safest using the sheath obturator. And whenever we are crossing this the membranous urethra, this cystoscope will be directed anteriorly, and it is advanced into the bladder. In the man, the penis should be have the maximal stretch in order to strengthen the urethra. It should be held at that 45 to 90 degree. That means in the stretch position in order to strengthen the urethra in all 5 fingers with a non-dominant hand. And we should try to introduce the cystoscope. And in the case of the flexible cystoscope, what happens that whenever we are inserting the cystoscope, once it is inserted a few centimeters, then we have to use the index finger and the thumb, and it should be inserted like a Foley's catheter. Now, whenever we are using the 30-degree lens, the visualization of the lateral walls that should be accomplished while whenever we are turning to the left side or to the right side, the camera orientation should be fixed and to rotate the cystoscope. And if we have completed the procedure and once the scope is withdrawn, it is prudent to leave the bladder partially full because of placing Foley's catheter. Now moving towards the ureteroscopy.
Dr. Bakhtavar, you see the numbers written on this cystoscope sheet, right? Can you describe what are these and what they demonstrate or denote?
Anyone from the class can describe that what is written here, what the 22 indicates and what these numbers indicate? No one.
Ji Bakhtavar.
22 indicates the sheath of the working sheath size, 22 fringe.
Right. And others? Okay. The largest number right below the inlet and above the outlet channel describes the sheath size that you have said, 17, 22. And the other smaller numbers, there are 3 basic parts. One is the sheath, one is the telescope. Telescope has got an eyepiece, the other one is an objective. In between these two is a bridge. Okay. Now the bridges have got dual purposes. It is to connect these two, and the other one is it can negotiate further working instruments. Now these smaller numbers depict the size of working instruments that can be passed through those channels. It's actually not the size of the instrument, but the size of the working channel. 2 individual numbers describe 2 smaller channels, and if in place of these 2 you can use one, that would be a bigger one that is described at the lowermost section, which would obviously be larger in size.
Now, as far as the ureteroscopy is concerned, we're using an instrument known as the URS, ureteroscope. Again, like the cystoscope, it is of semi-rigid and the flexible. Now, the sizes of this semi-ureteroscope are 6/7.5, 7/8.5, 8/9.8. Usually, we use on shorter length URS for the females, for because of even shorter length of the urethra, and the longer length ureteroscope are used for the males.
URS is described in 2 digits, 2 numbers. That is unlike the cystoscopes. Every URS has an oblique in between the 2 numbers, 7 oblique 8.5, 6 oblique 7.5. They come in different lengths as well, as Bilal has just mentioned. No URS has got a tip size larger than 7 to 8 FR. The shaft is obviously large, more broader and more wider in size.
Yes, definitely. That we are, as we have described, for example, if the 6 7.5, that means the diameter or the size of tip is 6 FR. It is increasing proximally. That is from an distal to the proximal. That is a 7.5, right? The parts of the ureteroscope, again, that this ureteroscope has got this is a telescopic this is a telescope, and this is an inline telescope, and this is again an ocular window and eyepiece, and this is a straight telescope, and this telescope, it goes upward in an oblique fashion and again turns like making an acute angle. This is known as the Merburger type of eyepiece. And again, this bachelor type of eyepiece in this telescope, it comes at an obliquely and it attaches to the bridge. And that is known as an bachelor type eyepiece. So the parts, like I told you, the eyepiece, inline and offset, the body, which has got the working channel, the light pillar, and the working channels, single working channel and double working channel. And again, the seat size 7 is a tip, and increasing proximally, the size increases, that is an 8.5 or whatsoever. These are the parts of the semi-ureteroscope. This is the shaft, this is the light pillar, and again a telescope, and the working channels.
Why do we use an URS with offset eyepiece? A URS with offset eyepiece. Have you ever used one? It actually helps with easier instrumentation, the working instruments that you might need to introduce with an offset eyepiece that will provide you a straight channel for your working instrument. If with an inline eyepiece, that working instrument would be in line with the eyepiece already, that would be a difficult manipulation.
Now, as far as deflecting mechanism, the flexible ureteroscopic is concerned, it is very important. Try to understand these the mechanisms, the active deflection, and what is the passive deflection. The active deflection, and it is of the two types, intuitive and counterintuitive. And this active deflection, for example, this is an flexible URS, and this URS, it has got a lever. And whenever we are using the lever, and while maneuvering this URS, it reflects. For example, if we want to approach the lower calyx, and whenever it deflects in the same direction of the lever, that is not the intuitive, and when it deflects in a direction that is opposite to that of the lever, it is counterintuitive. Now, what is a passive? The passive deflection, actually, when if we are using this distal tip that deflects proximal to this, if we are that means this is we are not utilizing the lever in that case. If we are approaching the pelvis, and we are it is once it's attached with the wall, and it deflects other than the lever, this is the passive deflection. And this is an reticle which is seen as a notch. It should describe regarding the plane of the deflection or utilization of flexible ureteroscope. Now, this is an passive deflection, as I described, and active deflection occurs at a distal tip to gain further length of the lower pole calyx. Secondary passive deflection is achieved by incorporating the flexible segment of the ureteroscope that's proximal to the point of active deflection. And tip of the instrument, it passively bent off renal pelvis to gain further length. Difficult to maneuver in dilated pelvis. Now, what is an exaggerated deflection? It is again of the type of active deflection. If once we have deflected this tip of this flexible URS, if we want to further approach the difficult area, we should have a 300 degrees rotation of the tip of the URS, and this is known as an exaggerated deflection, type of active deflection.
Could we understand what active deflection is? Hajra, you couldn't. The active deflection is actually what we do manually. How do we do it manually? I'll tell you later on. Passive is that you cannot do manually, right? For active deflection, flexible cystoscopes or ureteroscopes are provided with the lever that is attached to the handpiece, which the operator is holding, right? When you move the lever downwards, the tip of the instrument that is inside the body will move downward or upward. If it is moving in the direction of the movement of the lever, that is intuitive. Okay, you're moving the lever down, down is down, up is up. Okay, that is intuitive. And vice versa would be counterintuitive. This is active deflection. We use active deflection to negotiate our scope through, you say, high bladder necks or difficult narrow segments, or to visualize the bladder right, left lateral walls, etc. What passive deflection is, it comes into play where we have to negotiate flexible ureteroscopes, especially into the lower calices of the kidney. For passive deflection, the ureteroscope has an inbuilt flexible segment just few centimeters proximal to the tip of the scope. Now, what we do is that we put that ureteroscope's distal end against some support, let's say renal pelvis, and we bend it here manually. It causes deflection or bending of the instrument. Then we can obviously do the active deflection to reach the lower calyx. The lower calyx cannot be reached with active deflection alone because it permits deflection up to 180 to 10 degrees at max. Can visualize the lower calyx with active deflection, but to perform a procedure there, it needs further deflection. Then comes into play passive deflection or exaggerated deflection, right?
Now, these are the required instrumentations of the ureteroscope. Although it is difficult to describe the details of each and every instrument which are used in the ureteroscopy, but I will name a couple of these, such as in the ureteroscope, we are for ureteral access, we are using the guide wires, we're using the ureteric catheters, we're using the ureter dilators, we're using the ureter access sheath. The guide wires, again, the coating of what the guide wire has got the core and the coating. Core is inside, and what is it is coated by, for example, if it's coated by this polytetrafluoroethylene, the hydrophilic coated or hydrophilic tip, right? And the core of the guide wire, such as if it is made up of nitinol, it provides strength and rigidity and prevents the kinking of this guide wire. And ureteric catheter, again, such as the straight and angle ureteric catheter, and ureteral dilators, sequential ureteral dilators, balloon dilators, and ureteral axis sheath. We describe what is ureteral axis sheath and various lengths and diameters, and intercorporeal lithotripters, Holly-Ollier, pneumatic lithotripter, electrohydraulic lithotripter, and the baskets and stone retrieval devices. The baskets, again, made up of nitinol and stainless steel, and ureter occluding devices, anterior propulsion devices, and for post-operative ureter stains. Now, as far as the guide wires are concerned, the diameter of the guide wire, it varies mostly from 0.018 to 0.038, average is 0.035. The length of the guide wire must be remembered that is from a range phase is 80 to 260 centimeter, and average is 145 centimeter. Regarding the tip of this guide wire, it can be straight, it can be angled, it can be J-tipped. And again, as I mentioned regarding the core of the guide wire, the core is made up of nitinol, which gives the guide wire the strength. It makes it kink resistant and stiffer, rather than stainless steel core. While for example, if it is coated, this whenever we are using the glide wire initially in the ureter in order to prevent the perforation and trauma, and some glide wires have got the hydrophilic polymer, and these are actually very slippery. and instead of polytetrafluoroethylene. So they are not used, not reliable as a safety guide wire. As far as ureteral access sheaths are concerned, again, this ureteral access sheath, it has got an obturator. It has got this outer sheath, and the advantages of this ureteral access sheath, if we are once we are introducing this ureteral access sheath over the guide wire, it keeps the intra-pelvic pressure that is low. It helps in the stone retrieval. It prevents repeated entries of the instrument into the pelvic leaflet system, and this is available in the sizes that is 11 to 16 FR outer diameter. Again, as we described in the tables regarding the stone retrieval devices, the baskets, the grasping forceps, baskets again and helical, flat wire, other, and the material of used, the polytetrafluoroethylene, polyamide, and regarding the nitinol, the wires, the baskets, the nitinol baskets that have got the memory. That means if we are approaching about the stone in order to prevent the retropulsion, and if it is this basket is deployed, and in order to prevent this retropulsion, and this nitinol alive, it will help in maintaining the shape of again regaining a shape to the basket, and it will prevent the kinking, and it will open safely. And surgeon should be able to see the ureter endoscope and stone, what is called during extraction. Regarding the patient preparation, again the AUA guidelines, AEO guidelines. Regarding AUA guidelines, again for operating endoscopy, every patient should receive the antibiotic prophylaxis, irrespective of the positive culture. Regarding EAU guidelines for low risk procedures, it is again at the mercy of the clinician to opt for use or utilization of antibiotics. And again, then for anesthesia, it can be endotracheal or through the laryngeal mass airway, that means LMA, and regional, local with sedation. And if we are performing this urological procedure, it should be performed in sterilized and in a fully equipped room. Regarding the technique of ureteroscopy, again we will make the what is called that is an lithotomy position, and the contralateral leg that is elevated, and it allows the easy introduction of this ureteroscope. Now, in order to maintain the access that is up to the ureter, where you utilizing, for example, initially the cystoscope, and they are placing the guide wire and up to the pelvic leaflet system, and then following this guide wire, we will insert the URS. And the care must be taken to in order to whenever we are moving this URS, and what is called we try to this negotiate through this impacted stone. It can cause the perforation of the URS, and that's why the angle tip, the slippery, the hydrophilic coated glide wire, they can be very helpful in case of these impacted stones. The angle talkable catheter, they can easily pass above the stones. Once we have got this pathway, the passage, what is called to above the stone, then we can easily pass the guide wire, and then we can use the URS in the safe fashion rather than providing the trauma. So, as the guide wire cannot be passed safely beyond the stone, the direct inspection of the ureter up to the stone with the rigid ureteroscope, it will permit the passage of the wire and the direct vision. And once the access over the stone and the teeth, the hydrophilic wire is exchanged for the more secure. As I told you, once access is achieved, hydrophilic wire is exchanged for more secure standard 0.038-inch diameter Teflon coated glide wire. It is replaced with guide wire. If any suspicion of the infection, that is, for example, if you are inserting this, we are once we are cannulating the ureter with an uretic catheter, if the pus is coming out or possible of suspicion infection, the open-ended for drainage we use open-ended catheter, uretic catheter. Now, in case of difficulty of in approaching this due to the narrow lumen, we are passing the two guide wires, and in order to have the Caesar effect, And once we will try to negotiate a URS in between these two guide wires.
Dr. Adil Yusufzai, you have seen there is one method of negotiating a difficult ureter through railroad method, where we introduce double wires, like in the last slide. How do I identify a ureteric orifice that you cannot see in the first place? What maneuvers, what procedures can you do? Anyone else? Right.
Or we can inject a type of dye and wait for some time. It will come from the ureteric orifice if it is patent and draining the system.
Can we change lens? Okay. Changing lens to 30 and 70 degrees also helps. Also, overfilling, if the bladder is overfilled, the ureteric orifices might be displaced too laterally. Or if it is underfilled, the mucosal folds will cause obscuring of the vision. Okay. So you're right.
Now the last slide. We are concluding this session of the presentation of principle of endoscopy. Regarding then instrument care, we must also, rather than performing the surgery, we also should care for the instruments. And whenever we are using the laser fiber through these scopes, the golden rule is that do not step on the pedal once if you cannot see the tip of this fiber in contact with the stone, rather than in contact with the tip of the instrument, and we depress the pedal, and then you can damage these instruments. And for cleaning the instrument, we use a warm water, non-abrasive detergents, the sterilization, gas, ethylene oxide, glutathione, parasitic acid, stereo system. So that was my presentation. Hope you have. Hope I described most of the things in the nutshell.